Good morning. Thank you for the opportunity to talk about essential hospitals and the work that our hospitals do in population health, and specifically the workforce needs. That clock runs very fast. I'm going to go as fast as I can. If I can figure out. I might need help. Advancing slides. Oh, here you go. So many people wouldn't know who essential hospitals are, and I didn't know until I took this job. So quickly, who are we? America's Essential Hospitals is, I'm sure I'm doing something wrong here. America's Essential Hospitals is an association of nearly 300 member hospitals around the country. And what ties our hospitals together is the mission to serve vulnerable population. So that's a core mission. And the 4 additional characteristics that you will find about our hospitals is, 1, training. Our member hospitals train more than 3 times more physicians and clinicians in this country than other US hospitals, which is, until we say that out loud, it's surprising to hear that safety net hospitals do that. And they provide comprehensive coordinated care through primary care and specialty care networks, providing specialized life-saving care, such as trauma care, burn care centers, NICU. Essential hospitals operate about 1/3 of level 1 trauma centers and 40% of the burn care beds in 10 large cities. So that gives you the magnitude of care that these hospitals provide. And actually, some of you may know us as National Association of Public Hospitals from 6-7 years ago. So that also explains to you our ties to public health department, and many of our hospitals are still part of a public health department or sometimes even function as a public health department in places like California. So this is a map showing the chronic conditions prevalence in this country. So you can see the darkest shade, of course, uneven distribution of disease in this country. And now if I overlay our hospitals membership in here, these are the communities that we serve. So that should explain who we are and who we serve in the community, which also comes with a cost about uncompensated care. Our hospitals provide 9 times more uncompensated care than other US hospitals. Okay. If Brian's data was bad, here I'm coming. Which also translates to margin. This is the US hospitals margin of 7.8% aggregate, and our member hospitals have a 1.6% aggregate margin. And if we take out the DSH payment, disproportionate share hospital payment, that's a whole nother roundtable you can have about, it will get down to -3.0. Okay? This all translates to communities too. Our hospitals serve patients who have social needs and social determinants of health being a major issue. 25.3 million individuals who are below poverty line, 19.4 million individuals without a health insurance, 10.1 million people with limited access to healthy food, and 350,000 homeless individuals. So the communities that our hospitals serve and the mission of our hospitals makes it a prime component of population health in some fashion, is why they should work and what they do in population health. So as soon as I say population health, I want to make sure I say tomato and you don't say tomato, and we are both saying the same vegetable and using it in the same fashion. So we use this model and adapted it from Jim Hester's model from CDC's paper in 2015, trying to explain what our hospitals do in population health. So the 1.0 is the episodic care. You come in, you get treated, you walk out, right? The next level is the 2.0, which is the care coordinated system. And this is, you take care of the patient, but you also make sure they go home and take the medication, fill the medication. So the denominator here is your patient population. And then the third level is the community integrated healthcare. This is where it's beyond the hospital walls. The denominator is not patients anymore. The denominator is the whole community, which is community integrated healthcare. So we define community integrated healthcare as strategy by which healthcare providers work with other sectors. We're very clear about that. Work with other sectors in both complementary and collaborative ways to promote health. So this is the model that we use to explain what we think as population health is. And that was more about the denominator, right? The patient population versus community as a whole. Now let me peel this onion in a different fashion. Think about this in a two spectrum angle, the X quadrant and the Y quadrant. If your X quadrant is your denominator, patient population and community, and your Y quadrant is more about the interventions, downstream and upstream. If we can click a couple times. So providing food for patient, it's a downstream, it's just for patients. Healthy cooking classes, great, but still just for their patients. But now let's get into the community level. Having a food bank open to the community, great, it's a community level. Still, is it truly, are we addressing the social determinant of health? It's about the access and the affordability of these foods is what eventually we need to get to, which is the topmost right quadrant, right? So we would like our hospitals to be part of all four in some fashion. Think about the previous model that I showed you about the 1-pointer, 2-pointer, 3-pointer. We want our hospitals to be involved in 3-pointer, but should be still doing a good job at 1-pointer. Do we want to go into a hospital and not get a good care? That's not what we want. So we see this as a whole spectrum. As a matter of fact, in our office, we joke about some of our member programs is it 2.25-ish or 2.5-ish? And that's completely fine. It's a spectrum, right? And there needs to be a combination of pieces together. This is so complex that we don't want to say there's a magic bullet if you go to 3-pointer. So what have we done as an association, which is we provide research, education, and leadership development, of course, policy and advocacy support for our membership, but we are the voice of these 300-plus safety net hospitals. So what have we done? Our hospitals have been working on population health for a long time. However, a strategic approach came in 2015 and 2016. We conducted member surveys, expert interviews. Many of you we have talked with you during this interview process, key informant interviews within our membership, and a deliberative summit to understand what are hospitals doing in population health? What do they mean by population health? And what are the facilitators and barriers in this work? Quick summary of our survey. We got representation from 106 essential hospitals responding to the survey, and we conducted interviews to dig deeper because some of the survey questions didn't give us the full breadth of information. So obviously, first thing that they asked for is funding. Show me the money. However, it was not just show me the money. It was show me the right money. In the sense, they didn't want to be grant dependent. They wanted a stable venue as how these works should be funded. And payment alignment was a huge piece that we hear, especially for a hospital, you saw the margins. Payment alignment makes a difference in how they get involved in community integrated healthcare. The next was data and analytical tools. You wouldn't be surprised. It also came across very strongly about alignment pieces. How do I share data? The next pieces were all packaged as human capital, which is the staff training, leadership, and sheer need for staff. You can see here, there's a loud ask for the right people and more of the right people to work in this area. You would have heard the titles as vice presidents and directors of population health in many of the hospitals coming up. It's great, but that's not a magic bullet again. And actually, those are the people that we encounter quite often asking for help. Help us in this area. We are not trained in this area. And that's loud and clear in one of the next work that we have done, funded by Kresge Foundation. We looked into job descriptions of these folks and interviews and also focus groups with them. Many of them didn't have a job description. And that was a surprise to me initially, but that also gave us the thought that there's not much defined roles here. And that helped us, got us to the next round of work, that these are one people, at many hospitals, this is one person shop, not much of, and many of the peers didn't know what they were doing. So that didn't even get enough credibility internally in the hospitals to publicize themselves outside with the community. Other issues that we heard was many of them were hospital COOs or CFOs who became VPs of population health, and they were not trained in this area. So that led us to more work in looking into what are the roles and activities these VPs or directors of population health need to do. This wouldn't be a surprise to you. This is common in every single competency, right? Like I was part of public health MPH competencies 15 years ago, but this is what we see. However, it's about the context. What leadership internally and externally, the communications internally and externally that's needed. And the main pieces here was operating environment. Each one had a different set of operating environment. Some were part of an ACO risk-based model, had a totally different approach than a public hospital in California. Contra Costa had a different approach than Henry Ford would have. So operating environment is a huge piece. And another one was internal structure, as where these population health activities were based and how they were dispersed. In the interest of time, the next piece so we as a membership association are trying to support our membership in the work they do. And this is one piece of the puzzle for population health. And quite often I heard from CEOs, I want to support this work. I want to hire someone to lead this work. I don't know who to find, who these people are, how to find them, what are the skills that I need to look for. So we, as of yesterday, published a toolkit, which is outside if you would like to grab, which talks about who are these people, who's population health executives, what are the skill sets needed. Don't worry, I didn't call the word competencies out. It's skill sets. All the accreditation people. It's just skill sets. And also has a job description template. We're trying to feed it, like to help people to get into this work and make it easy. Job description template and an assessment for their job. So again, we are not trying to create a cohort here. We are trying to support and effectively make the existing cohort work and align with the rest of the world. So, one other piece that I'll add is because of our reach in training the future physicians and future clinical leaders, we are also working with directors of graduate medical education so that they could incorporate population health activities into their training program and residency. That was quick. And that's a lot of information. Almost all of this resides in our website, essentialcommunities.org. Thank you. Actually, there was a cartoon there which said, if you can tell what your job is, you can have your job. So that's what